So great to be able to speak to you. It's actually my first time presenting at Urology Rounds, even though we share a floor. We often share the elevator, usually at 5:50 in the morning. I'm traveling up with some of you. And it's been fantastic over the last 2 years to be able to cross the great divide on the 6th floor from men's health to women's health in one of the projects that I'll be talking to you about in the latter portion of my talk. Hope is that we'll save lots of time for questions. So please feel free to make this as interactive as you would like, and feel free to interrupt as we go along. So briefly, some of the things that I hope to cover during this presentation are to talk about some of the larger recent studies examining the prevalence of sexual health concerns in men following prostate cancer treatment. We'll then review some of the evidence on the efficacy of non-pharmacological adjuvant treatments for improving sexual function in men following prostate cancer. And then finally, to get you excited about a study. And this study has been a great collaboration. Goldenberg, Tia Hagano, some folks on our side in OBGYN, and hopefully to stimulate some ideas about recruitment. So first of all, to put some of the questions you might have around the prevalence of sexual concerns following prostate cancer into context, I'm going to talk just very briefly about some of the major categories of sexual dysfunction that exist. So these are categorized by the ICD, the International Classification of Diseases, as well as the DSM, which is the Diagnostic and Statistical Manual of Mental Disorders. Within sexual health, broadly defined, which is transdisciplinary, those tend to be the two most common classification systems that we use to categorize sexual concerns. So by far, not all of them, but the three most common men's sexual health concerns that are documented in the literature are, first of all, hypoactive sexual desire disorder. How many of you have assessed this or treated this? Hypoactive sexual desire disorder in men, show of hands. You've assessed or treated this. Chris, I know you have. Brian, for sure. So essentially, this is the man who reports a lack of interest in sexual activity, perhaps a reduced interest from before. So there can be a lifelong pattern in which the individual indicates for the entire existence of his sexual career, so to speak, he's had a low interest in sex. Or this may be a recent change, perhaps with a new onset as a result of treatment or stress or medication, etc. In order to be formally classified as a sexual dysfunction, the symptoms have to persist for 6 months. And this is to account for transient and normative changes in sexual desire that we might expect. If there's a brief period of time where the man is undergoing a significant stressor in his life, or if there's some short-term change in health status, we might expect that his interest in sex has been reduced. And once that event has passed, his desire might resume to a normal level. So when we're talking about a desire disorder or a dysfunction, we're really talking about lasting difficulties in desire. We also want to make sure that we rule out other common explanations. So if he really dislikes his partner or is in a very unhappy relationship with a lot of conflict, again, it would make sense that his desire is reduced. And we wouldn't diagnose that as a sexual desire dysfunction. Of course, we would still talk about treatment interventions, but we might be focused a bit more on the couple dynamics and the couple conflict. Secondly, perhaps the one that you're very, very familiar with in this audience, how many of you regularly assess and treat erectile dysfunction, erectile disorder? I'm sure all the hands are going to fly up in the room. So the DSM classification indicates that... Sure. Yeah. So within sexual medicine, we tend to use those terms interchangeably. Libido, desire, interest can be used very interchangeably. And, we can diverge and talk about, well, there's sort of an innate biological urge, and maybe we talk about libido when we talk about that urge. But increasingly, the science of desire, and this is where I spend most of my time, is really understanding what is desire and the nature of it. The science indicates that for men and for women, that it's more responsive. And what I mean by that is that it emerges in response to something, whether it's an erotic cue or a memory or having a certain kind of stimulation. So it can be quite common for individuals to maybe not have or not feel a strong level of desire, but that it emerges in response to a competent sexual cue, right? So we really talk about desire as encompassing all of that. And so in the context of treating desire, which we're actually not going to talk about, much of the focus is around what are the kinds of cues and triggers you're exposed to? What are the kinds of stimulation, and are they effective for you? Given that our response to cues might change over a lifetime, and certainly over the course of a long relationship. Good question. So ED, any one of the following: difficulty getting erection, difficulty keeping erection, or decreases in erectile rigidity. Again, the difficulties persisting for 6 months to meet formal classification. You might intervene with treatment earlier than that, especially if the man is very distressed by this. And again, we want to rule out relationship or contextual factors that completely account for the erectile dysfunction. Now, in all cases, and Brian I'm sure can verify this, there's often an interplay of biological, psychological, and social factors. So sometimes it can be very, very difficult to tease out to what extent is this because of relationship conflict versus biology versus something else. And so we do the best we can in teasing those different components apart. Third, premature ejaculation. Formal classification is the man who ejaculates within 1 minute of penetration. So that's ICD classification as well as DSM-5 classification. Symptoms have to persist, and again, ruling out other relationship conflicts. The literature has been quite controversial around how this definition fits for gay, bisexual, and men who have sex with men, where we actually don't have enough data to be able to conclusively say that 1 minute criterion fits for non-vaginal intercourse kinds of penetration activities. So this is definitely an area of research that we need a lot more data. So among gay and bisexual and MSM, what does their premature ejaculation look like? Is that 1 minute threshold still fit? There's some really good work happening on this in the Netherlands, but still a long way to go. So as I mentioned, although these are 3 of the most common sexual dysfunctions in men, there are many, many others, and that you will also see in urology. So climacturia, anorgasmia, fecal incontinence, penile shortening, peyronie's, etc., etc. So again, putting this in context, what do we know about the national prevalence of sexual dysfunction in men? So there have been many, many different representative, large-scale studies. One of my favorite ones, one of the most representative ones, was a study that was done in Britain. This is the 3rd wave. So the first one was done in the late 80s and the late 90s and then the mid-2000s. It's called the National Survey of Sexual Attitudes and Lifestyles, or NATSAL. And what makes NATSAL so unique is that it involved interviewers going door to door, knocking on doors, and assessing sexual function right there. The response rate was close to 70%. So one of the highest. I mean, imagine you're at home eating dinner, someone shows up and asks if they can take 45 minutes of your time to ask you about your sex life. It's unheard of. I have no idea how they were able to get such a great response rate, but they did. They also took, which I won't be talking about in my talk today, but they took salivary samples on 70% of the population to look at different hormone parameters. And among the women, about 65% of them also took a vaginal smear. So interviewer waited downstairs, woman went and collected a vaginal smear. Unbelievable, isn't it? Unbelievable. I think that's why I cite this study so often. So what did NATSAL tell us? So the question that was asked was, over the last year, have you had a period of 3 months or more where you had any of the following sexual concerns? And you can see the data here. So for men, the most common sexual concern was lack of interest in sex or low desire. By the way, this is the most common sexual dysfunction in men that shows up study after study after study. Most folks think that it's ED that's the most prevalent. It's actually low desire in men. And all of the studies have found this within a general population. We're not talking about specific subpopulations. So ED second most common, and you can see that for both men and for women, desire discrepancy was also very common. So about almost a third of the sample. And what I mean by desire discrepancy is for those folks who are in a relationship, their ideal levels of desire are mismatched, right? So it may be because one person's desire is too high and the other person's desire is normal, or one is normal and one is too low. But it's the mismatch that creates the distress. And in my clinical practice, this is what I see a lot. And it's not necessarily as gendered as we might think. We might assume that in a heterosexual couple, it's the man who has the higher desire, the woman who has the lower. Among the 10 or so couples I'm seeing right now with discrepant desire, it's half and half. Okay, so in half the cases, the man has the lower desire, in half the cases, the woman has the lower desire. So keep these numbers in mind as we shift in just a moment and talk about what about the prevalence of sexual concerns after prostate cancer. So collectively in the NatSol study, they found that about just over 40% of men reported at least one problem sexually over the last year, 13% two or more. Those are high numbers, really, really high numbers. Obviously, the study was not able to do an in-depth clinical interview to find out, are these concerns distressing to you? How long beyond 3 months have they lasted? So some of the nuance was missing. But when we look at a broad kind of conclusion, we can see that sexual concerns are common in men, even more common in women. All right, let's shift. We're going to focus now for the rest of our time together specifically on prostate cancer. So what do we know about prostate cancer? 1 in 8 men. And we know that with advances in treatment, that survivorship has become increasingly very, very important. So how do we enhance the quality of life in men who are surviving prostate cancer? And one of the things that we know is that among the various supportive care needs, sexual health is consistently listed as the top need. So among a long list of quality of life related aspects, financial, feeling like myself, sense of identity, mood, adjustment, relationship roles, it's consistently sexual health and intimacy that rank near the top. In other words, men saying, this is the domain where I have ongoing concerns and where I really want some help. So what does the literature tell us? There have been scads of studies looking at the prevalence of sexual dysfunction, sexual health concerns after prostate cancer. In the early 2000s, there were at least 3 meta-analyses done. This is a literature that I think deserves to be updated regularly, particularly with advances in treatment. And so our data on what are the prevalence of sexual concerns has evolved over time. So I've done my best to only report recent data. You can fly your hand up and say, you're missing that important paper. I'm sure I'm missing several, but here's sort of the current state of the literature. So first of all, this was a fairly recent study published in the New England Journal, and it looked at men who were randomized to active monitoring, radical prostatectomy, and radiotherapy, and they were followed for 6 years. They were randomized. It is protect. Yeah, they were randomized in this study. Yeah, I had the same reaction as you because I'm not aware within treatment of gynecologic cancer where women were ever randomized to active monitoring. And among their various outcomes, one of their outcomes was looking at the prevalence of good erections. And by good erections, these were self-reported by men as being erections good enough for penetration. Okay, so those are some of the data. So the prevalence data that I'm going to be showing you now are the proportion of men who reported that their erection was good enough for penetration. So just looking at some of the baseline data, 2/3 of the men before treatment stated that that their erections were sufficient for intercourse or penetration. What happened at 6 months? The active monitoring arm, half the men continued to have good erections, 22% in the radical prostatectomy arm, and 12% in the radiotherapy arm. What happened to these men in the long term? You can see the numbers there. So the numbers sort of go up and down. In particular, the radiotherapy arm, there's some recovery of function, but in the radical prostatectomy arm, there was a small but significant decrease in the proportion of men who said they had erections good enough for penetration. Here's a graph of the same question, but assessed with a validated measure. And so this is looking at the proportion of men in the same trial who reported a problem with erectile dysfunction. So you can see the red bars, radical prostatectomy, the highest prevalence of sexual concerns over the 6 years, followed by radiotherapy and active monitoring. There's also been a lot of interest in looking at what are the baseline predictors of those men who might be more likely to develop erectile dysfunction, or the men who are more likely to have some preservation or recovery of erectile function. So this was a study following only nerve-sparing radical prostatectomy, and they were followed every 3 months for 3 years. And what they did in this study is they were able to stratify the men according to baseline risk groups. So these are indicators that could be assessed at baseline pre-treatment that would allow you to make some predictions about what is your likelihood of recovering your erectile function. So the lowest risk group were the younger men. They were also the men who had an intermediate score on the International Index of Erectile Function, a widely used validated measure of sexual function, not only ED, but other domains of sexuality, and the Charleston Comorbidity Index, which is an index calculator that assesses the 10-year survival or mortality risk in patients with several comorbidities. So lower comorbidity index, and their likelihood of recovery was about 85%. The medium group were the men who were slightly older, lower scores on the IAEF, and a similar comorbidity index. You can see 59% of those men, so age really being a significant predictor here. And then finally, those men in the highest risk group were the oldest men, the lowest scores on the validated measures, and having multiple comorbidities. And their chance of recovery at the 3-year mark was about a third. So when we're thinking about counseling men at pre-treatment, and we'll come to that in a few moments, there are some existing data that will allow you to inform your conversation with men about what is their likelihood of potentially regaining their erections. What about gay men, bisexual men, and men who have sex with men? Is anyone involved in this work here from a research perspective? And what about clinically? How many of you see MSM, gay, bi men? Okay, a few of you. So there was a study that was happening here I was involved with about 5 years ago, where we validated a measure of sexual function for gay, bisexual, and MSM, given the unique expressions of their sexual activity. So for receptive men or bottoms, their erections are perhaps less important to them than are the feelings of pleasure with receptive anal intercourse. On the other hand, for the penetrative men or the tops, having a solid erection, in fact, erections being more important perhaps than for vaginal intercourse to allow for anal penetration. So there's been a fair bit of research by Gary Dossett in Australia, Usher and others, looking at what are the unique needs among gay bisexual men and how can we fold that into our counseling with them at pre-treatment. So in this large comparison of gay bi MSM men to heterosexual men, they were followed every 3 months for 3 years, and they looked at a number of different facets of sexual function. What did they find? Well, they found actually on measures of sexual function that the gay bi and MSM had higher levels. So they had higher self-reported levels of sexual function. Their quality of life was the same in the two groups, but lower than an age-matched non-cancer sample of gay and straight men. What about their sexual communication? There was no difference between the groups, but on average it was lower among these prostate cancer survivors. And I think one of the most interesting findings of the study was that the gay, bisexual, and MSM men had much, much higher levels of distress, of sex-related and psychological distress. So in terms of insults to their feelings of masculinity and performance and sense of self, even though their rates of sexual function were higher than the straight men, their perceptions of psychological function and sex-related distress was higher, more distress in that sample. Very, very briefly, this was a recent study published in the International Journal of Urology among 482 Japanese men after permanent brachytherapy for prostate cancer. And I put this slide up to remind us about cultural, ethnic, religious, contextual, and sociocultural differences in the patients that we see. And so keeping in mind that even the meaning of erection differs across culture. And so in this study, this looks at the prevalence of how common erection sufficient for intercourse was. You can see that the numbers on average are a bit lower than the comparative studies I showed you. However, sex-related distress was not that high in this sample. So there can sometimes be a mismatch between, does someone have a sexual dysfunction, are they bothered by it? And so we can't assume that they're the same. We can't assume that a sexual dysfunction connotes distress or that it doesn't. So it's important to ask that. All right, we're going to shift. And here's where I feel a bit more at home, given I spend the majority of my time on women's sexual health. But what about the partners? And so there's recognition, appreciation that prostate cancer is a couple's disease. Yes, the man was the patient, received the treatment, received the follow-up, but the partner, whether it's a female partner or a male partner, and there's been a good body of literature focusing on both, they're impacted. And they're impacted not only in terms of their psychological adjustment, but their sexual function can also be impacted. So this one study published about 10 years ago in the New England Journal looked at about 1,200 survivors, and half of them had their partners interviewed. So what did they find? Well, they found, so this is the prevalence of poor erections in radical prostatectomy, external beam radiotherapy, and brachytherapy at 24 months. They then asked the men themselves, to what extent are you bothered by your erectile dysfunction? And so the data I'm going to show you are only the men that reported a fairly high level of bother, right? So you can be minimally bothered, you can be moderately bothered. These are the guys who are really bothered by it. So half of the men in the surgery group and about a third in the other two groups reported that they were quite significantly bothered by it. What about their partners? To what extent were the women bothered or impacted? You can see the numbers are pretty high. So 44% of the partners indicated that this is a big problem. It says to partner, it's actually about the partner, but it's her own subjective feelings of distress and bother. So fairly high levels of bother in partners. And just curious, how often, maybe throw out a percentage of the men that you see, what percentage of them bring their partners throughout consultation and treatment and follow-up? 20 to 30%. Okay, so most don't. Mm-hmm. They actually did control for age in this study. We tend to see more bother among younger individuals rather than older individuals. And you see that whether you're looking at men alone, women alone, or as a couple. All right, so we're going to shift. So what do we know about non-pharmacological approaches? So this is not a talk about PDE5 inhibitors. You're all the experts in that domain. This is about why would we consider ancillary treatments, non-pharmacological treatments. And there's a number of reasons why we would do that. So first of all, we know that PDE5 inhibitors have variable efficacy in prostate cancer. Not all men respond to PDE5 inhibitors, and that's the case in prostate cancer, but also outside of prostate cancer. This isn't specific to that population. There's also evidence that efficacy in some men may decrease over time. Now, whether this is indeed a reduction in drug efficacy or if there are problems in compliance or other issues that might be complicating the efficacy of the medication have all been looked at. There's also some data that suggests that failure rates can be as high as 80%. Some men simply can't afford it. And that's a real barrier for many folks, especially living in more geographic, remote areas of our province and our country and our world. And this has been an area where there's been a lot of interest is around what's contributing to those discontinuation rates. And very interestingly, most of the data show that discontinuation of use of PDE5 inhibitors does not necessarily depend on how efficacious they are. So why are men discontinuing? Is it financial? Is it responses of the partner? What are the reasons behind that? So these are some of the reasons I think it's compelling at least to consider other non-pharmacological treatments that can be used either in conjunction with, maybe before, maybe after. That's an area that I think the science still needs to go, is what's the best combination of medications plus more psychosocial approaches. So sexual health we accept as a biopsychosocial phenomenon. So even the man with prostate cancer, where we can definitively link aspects of his treatment, whether it's the surgery, the radiation therapy, treatment of side effects, what have you, we can say the sexual change is due to this intervention. We also know that having the new identity as a cancer survivor can be very impactful, and its impact on mood. Fear of recurrence, which affects about 50% of cancer survivors broadly defined. And there tends to be a spike in fear of cancer recurrence once patients are no longer under regular surveillance. That's usually when I see them, is when their anxiety spikes, because they truly believe that when their doctor's no longer following them, that their cancer will come back. It's a bit of an irrational belief but they see those two as linked. Because my doctor's no longer following me, my cancer has a higher likelihood of coming back. In this room, of course, we can see that as irrational. To the patient, of course, it's experienced as very, very real. And then in terms of social influences, so if the man is unwell for a while and there's a shift in role status, where he's maybe no longer doing the things that he typically does, whether they're domestic related or relationship related or parenting or roles in his community or volunteering, what have you, all of those can directly impact his sense of self in a way that affects his sexual function. And these, of course, all interact with one another. There's some really great biopsychosocial research that looks at how do these different pieces evolve over time as people age and as they undergo different, or as they enter different life stages. So psychoeducation. So this is a logical first step to go, especially if you're not trained within sexual medicine, you don't have extensive experience in conducting a biopsychosocial sexual health interview. It makes sense that psychoeducation is the place to start. So educating around what do we know about the impacts of your impending treatment on sexual function, and here are some strategies for you to keep in your back pocket that we will talk about after treatment. Unfortunately, sometimes survivors feel that probably because there's the discussions are so much focused on the treatment itself and on recovery, that sometimes sexual health conversations don't happen, or they don't happen at a level that men feel is sufficient. Or maybe they are happening, but given the depth of information that men walk away with about their impending treatment, they miss that part of your intervention with them. So this is a man who is participating in our study right now, and this was from a few weeks ago, Faith? Yeah, a few weeks ago. So this is just one person's perspective, but to sort of frame the rest of the talk, I'll let you hear this. And this is not intended to point any fingers at anyone. Again, there might be multiple explanations for this man's experience.
I wasn't even prepared for it, which was very upsetting in terms of the medical profession not letting me know. I found out from a friend before my operation about how this was going to impact on me. So I wasn't even prepared for what was going to happen. I was basically told by a doctor that if I didn't have this surgery, I wouldn't be around for long. And so I said, well, I don't have much of an option. And because I was certainly questioning whether I wanted to have this operation because of how it was going to affect us sexually. So,
So that's one individual's perspective, the feeling of inadequate information provided around sexual function. Again, it may be that the information was provided and he didn't hear it. Or it may be that the information wasn't provided. The fact that this is a survivor's perspective and in our project, which I'll get to in a minute, we've heard many similar experiences to this. So there's a craving for, there's a wanting for more discussions around sexual function and normalizing it for them and providing a space where they feel safe and comfortable to talk about it. Oops, sorry.
I wasn't even prepared for it, which was very upsetting in terms of
sorry, I don't know how to turn that off.
Profession not letting me know. I found out from a friend before my operation about how this was going to impact on me.
Perfect. Okay. So what do we know about education? Again, education is a very logical place to start. So Leslie Shover, great, fantastic colleague of mine who's spent her entire career developing and testing psychoeducational and psychological interventions for sexual function, mostly after prostate cancer, conducted this randomized trial where she compared 6 to 8 peer-led, so these are telephone sessions led by survivors versus a combination of nurse full-day workshop plus a psychologist for 7 hours or usual care. The information that was provided was purely educational. There were no psychological skills or interventions that were given. And what did she find? Well, she found that in sorry, that says usual care. It should be the first two. So in the peer-led sessions and in the nurse psychologist sessions, that the men were 3.5 times more likely to use and comply with their medication. So great, this is fantastic, and a role for our allied health professionals in increasing compliance. And some of that is probably also discussion around the role of desire, discussions with men around the fact that PD5s, when you take them, don't simply work on their own, that stimulation is required, that sexual desire is absolutely necessary for those drugs to be efficacious. However, there was no impact on sexual function. So education alone does not improve sexual function. So this was reviewed much more recently by Daniela Whitman, also very, very well-known clinician researcher in the field of prostate cancer rehabilitation. And Daniela looked at the existing studies that have looked at psychoeducational interventions, both pilot studies and RCTs. What were the key learnings? And this is a great article to read because the clinical implication section of this paper is really quite long. So what did she find? Well, again, replicating Leslie Shover's findings, psychoeducation does improve medication compliance. Erections are important to men. And what she found was that when men were presented with a list of different aspects of sexual function that they would like to focus on and receive treatment for, that there was a primacy placed on the restoration of their erections. They also found that group interventions are feasible, and in fact, can be a great way of delivering information and psychoeducation in a cost-effective way. On the women's health side, we've moved almost exclusively to running our sessions in groups. There was also a finding that treatment should address the partner. Partners should be included. Partners also directly impact the extent to which men comply with sexual health treatment recommendations. And again, erections don't improve with education alone. And the conclusion of this paper is that maybe we should be doing more around helping these men to think more broadly about sexual function. So as there's a continual exploration on ways to improve their erections, can we talk about other ways to feel pleasure? Can we talk about other ways that don't depend on a firm erection for engaging in sexual activity? So we often talk about the sexual buffet. So broadening the sexual buffet. So that takes us to the last segment of this talk. And this is really intended to get you excited. And so this is, I'll give you a tiny bit of background, but essentially we've received funding from Movember Foundation to run an RCT that we're about 1 year into right now. So very, very briefly, how many of you have heard of cognitive behavioral therapy or CBT? Okay, half the group. Essentially, this is how do we change thought patterns and how do we change behaviors like avoidance, like chronic tension, like destructive behaviors? How do we change behaviors and thoughts as a way of changing emotions? Okay, so this is a very, very long-standing theory within psychology that thoughts, feelings, and behaviors interact with one another, and changing thoughts and changing behaviors can be very effective. So CBT has been used in the sexual health field for about 50 years, and lots of great data showing that CBT is effective. So we give individuals thought records where we ask them to track their thoughts. We talk about non-goal-directed sex. We talk about certain situations where they're more prone to having irrational thoughts. We talk about encountering avoidance, so maybe they're avoiding potential sexual encounters, communication skills, so using I statements, and behavioral experiments as well. And if anyone's interested in finding out more about CBT, feel free to talk to me about it afterwards. How many of you have heard about mindfulness? Okay, and how many of you practice mindfulness to some extent right now? I will right now. So that was my starting point, was if you knew about it, I was going to bypass defining it. So mindfulness essentially is defined as present moment, non-judgmental awareness. So it's about cultivating attention, bringing attention to a certain focus, and doing so in a what we call compassionate way. And by that, what I mean is not being hard on yourself if your mind gets distracted. So think about if you've made a gourmet meal or gone to a fantastic restaurant and then been so distracted by other things that you actually forgot what you ate. Or been in a conversation with someone and you're drifting off thinking about what you need to do in 20 minutes. So all of us are prone to the curious puppy mind, the idea that our minds are like puppies and they take off very, very easily. And the widespread availability of technology, which is a lifesaver for all of us, certainly promotes multitasking. So there's been a lot of interest in mindfulness. Time magazine covered it 4 years ago. They reissued this last year, covering much more data. It's been tried for a wide variety of different, not only psychological, but also more medical health conditions. It's not distraction. It's not about relaxing. It's not about turning your thoughts off or turning feelings off. It's about paying attention and doing so non-judgmentally. That's sort of the simplest definition of mindfulness. Within women's health, we've done this in many samples of gynae cancer survivors. We've done this with in clinics, women seeking care for sexual desire. We've done this in women with a history of sexual abuse who are now dissociating during sex. We run this regularly in our pain clinic, women experiencing vulvodynia. We've evolved over time from 2 to 3 to 4 to now 8 sessions. My book, which Ryan mentioned, summarizes the entire body of science of mindfulness for sex in women, but there's a chapter on men too. So even though women is in the title, I often say to people it's just as applicable to men as it is for women. What we don't know is exactly how mindfulness works to improve sexual function. We know that it improves mood. We know that it increases our ability to be interoceptively aware or know what's happening within our body and pick up on those cues. We know that it reduces anxiety, and anxiety being a major contributor to sexual dysfunction. We know that it increases self-compassion, so the man who says, unless I get that erection, my partner will leave me, or unless I can perform sexually, I'm not a real man, or if I can't have an erection, I'm not normal. So these really significant, catastrophic thoughts about sexual dysfunction can actually contribute to sexual difficulties, both sexual distress as well as sexual function themselves. The mechanisms is another talk. And simply, it reduces distraction. So we know that mindfulness is effective at bringing people in the moment, into the sexual encounter, to feel sensations and not be 5 steps ahead or thinking about something else. So we've done some pilot work in men. This had never been done before in men, but my former postdoc, Jen Bossio, we wrote a treatment manual and tested this out mostly as a feasibility study in men with situational erectile dysfunction. So these are men who could get erections with a partner, who could get erections on their own with masturbation, but with a partner they could not get erections. I'll just fast forward. So the men found that mindfulness was logical. They were quite motivated. They were motivated to practice at home. So mindfulness has a variety of skills that require home practice. They didn't have a high degree of expectation that it would do anything for their erections, but again, they were motivated. So we found a medium effect size. So it did significantly increase their total IIEF sexual functioning score, and an even larger effect size on their sexual satisfaction. And this makes sense given that part of the conversation with mindfulness is how do we broaden how we think about sexuality? How do we be open to other kinds of sexual expression, sexual activity? And the qualitative results were that they felt normalized, that they actually really enjoyed being in a group. And we were, at the beginning, really quite skeptical that what would happen when we brought these men together to talk about their situational ED. But they actually found it quite validating to be with other men. They liked having specific skills to practice, and then they provided some feedback around wanting more time, wanting a partner involved, etc. That paper's in press in the Journal of Sexual Medicine. So we then took that information and the skeleton of the mindfulness treatment and did a pilot study in prostate cancer survivors. And so this was the focus of Jen's postdoc, which ended about 6 months ago. This involved 4 weeks, so 4 2-hour sessions where the men came to us on the 6th floor. We ran the mindfulness sessions, we gave them homework, and we had pre, post, and 6-month follow-up measures. This was the impact study. Some of you may have heard or seen flyers for the impact study. We've got a lovely treatment manual for the facilitator as well as for the participant. Those were some of the core components. We had 14 couples run through it. So these were men and all female identified partners. So this was our first couple-based intervention. And what did the men tell us? Indeed, they told us that it was very helpful for them to frame the treatment around PC as a couple's disease. They also found it valuable to talk about the impact of their illness on sexual function. They actually really liked the mindfulness practice. Most of them had never been introduced to mindfulness before, so the underlying theory of how it works made a lot of sense to them. They were curious about the mechanisms for change. How can paying attention improve my sexual function? So we had an opportunity to get into that, into the group. And then we talked about some of the individual factors that would make it more likely for this to work for some men and not for others. So this set us up nicely to apply for a Movember Foundation grant. And this is the introspect study that Faith Miller, who's our study coordinator there, Faith Wave, so people know who you are. Send your patients to Faith. And this is a randomized controlled study. So again, focused on couples. 50 men are randomized to mindfulness, 50 to CBT, and 50 to treatment as usual. And so for both the mindfulness and CBT arms, we've developed and vetted out to men and had some feedback and therefore improved treatment manuals. So we've got a facilitator version as well as the participant version that has all of their handouts, all of their homework. So what do we hope to do in this study? We're about 1 year in. Well, first of all, having treatment manuals that are available can certainly help in training residents, training those who might have an interest in doing more sexual health work. And so we can actually use the treatment manuals as a training tool and expand the number of folks who are really interested in working in this area of sexual function within prostate cancer. We're also very interested in what are the individual predictors that might lead to different improvement trajectories, both in erectile function, but in also sexual satisfaction and in a variety of quality of life indicators. So who are the men and their partners? What are their characteristics that might lend them to respond more to mindfulness, for example, as opposed to CBT? And because we have a control group, we're able to follow what happens over time. Also, this is sort of our catch-all phrase that we use within grants. It's a platform, for others who might be interested in doing more within this area, this broader area of survivorship, but much more specifically on using psychosocial care. One of my interests in the long term is looking at how we can combine this with PDE5 inhibitors or other treatments, and how might this interaction impact their efficacy. So finally, how to refer. This is on the top left is our website, which is just brottolab.com. Men can self-refer to the study. There's Faith's photo and her email, Faith F. Miller at prostatecancer.com. We also have a pretty active Twitter handle. We got a lot of retweets from UBC and Prostate Cancer Foundation. We're actively involved in recruitment. In addition to including men after prostate cancer treatment, we've recently expanded our recruitment to include men in active surveillance. There's a few different reasons and some controversy around why would we expand this to men in active surveillance. What the data tell us is that the active surveillance men also have sexual health needs and their partners do as well. So hopefully we'll be powered enough to be able to differentiate the groups, the post-treatment versus the active surveillance men. But that's a little bit of an experimental arm in this study. So thank you. Hopefully all of our men are doing this at the end. But thank you very much for your attention. I'd love to hear ideas of how, ideas for how we might integrate this, should the trial prove to be effective, how we might consider integrating this into care, and any interest that you have in collaborating on the study or any questions. So thank you very much.